Hello.
Hello.
So here we are. I'm going to stop my sharing to allow you to share and see if that works, okay?
Yes.
Okay, sorry.
Yes, it works or not?
Good,
Yes.
excellent. So you can stop sharing and I'll put the slide back on if you don't mind.
Yes.
Thank you. I don't know why this echoes things that we say. I have to confess. Okay. I'm really worried because I hope this is not going to happen during the webinar.
The noise that you are hearing, or what do you mean?
Yeah, I listen to things twice.
Yeah, there's a sound, yeah. It's like a horse or something like that.
It's really weird. I'm going to log out and log in again, okay?
Okay.
Just say something. I'm going to mute my microphone to see if that happens or not.
That's okay. Now I don't hear anything anymore.
Going to leave the meeting and come back, okay?
Mm-hmm.
I'm back. I think I've solved the problem, which is good.
Nice.
Okay, let's put my slide on. Are you ready, Janneke?
Yes, I am.
Okay. Good afternoon. Welcome to the Euro-NMD webinar on painful neuropathies from diagnosis to treatment. I am Antonio Tavaye. I work as a clinical advisor to the ERN. And today's talk is about painful neuropathies and is by Janneke Uijmakers. She studied medicine in Amsterdam when she followed with training in neurology in Maastricht University Medical Center. Since the start of her education in 2010, she engaged in research about painful neuropathies in close collaboration with the University of Wales, Professor Waxman, and with the Institute Carlo Vesta in Milan with Professor Loria. In 2014, Janneke defended her dissertation on the role of sodium channel mutations in patients with small fiber neuropathy. An article from her thesis was awarded the Princess Beatrix Spearphones Annual Prize, for the best neuromuscular article published in 2012. Since January 2016, Janneke is working as a neurologist with a neuromuscular interest in the Maastricht University Medical Center. In addition to research in the field of painful neuropathies, she's also involved in myotonic dystrophy. She's a medical advisor for the diagnosis group Small Fiber Neuropathy of the Dutch Patients Organization for Neuromuscular Disorders, and she's also a board member of the Dutch Neuromuscular Center. Before passing the floor to Janneke, I wish to welcome everybody as well. And remember that in the webinar format, you are not allowed to speak during the talk or to have your video on. However, in the end, you will be able to unmute and put questions to Janneke. You can also and should also write those questions in the Q&A tool that is available for you during the webinar, and you can use the chat tool to discuss things among the audience or with us as well. So thank you, Janneke, for accepting to give this talk, and we are looking forward to learn from you. I'm going to stop my share. Please go ahead and share your screen, please.
Yes, thank you. Thank you for the introduction and for the opportunity to give this presentation during this webinar. And I don't have any conflicts of interest in relationship to this presentation. Well, today's presentation, it's all about pain. Everybody feels pain from time to time. And pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And in neuropathic pain, the pain is caused by a lesion or disease of the somatosensory nervous system. And in the general population, about 5 to 10% of persons experience neuropathic pain. And today I will focus on the lesions of the neuropathic, of the peripheral nervous system, and more specifically on painful neuropathy. Well, as you might know, the peripheral nervous system consists of different nerve fibers, and they are classified into fibers regarding their size, the axon diameter, the myelinization, and the conduction velocity. And damage to the peripheral nerves can cause peripheral neuropathies. If all types of nerves are affected, you speak of a mixed fiber neuropathy. If there's an isolated large fiber neuropathy, only the large nerve fibers are affected. And in small fiber neuropathy, the A delta and C fibers are damaged. Today, I will speak about this small fiber neuropathy. And that's because the A delta and C fibers are responsible for the sensation of pain and thermal sensation. And they are also involved in autonomic nervous system. And because pain is the main feature of small fiber neuropathy, I will focus on that. First, I will tell you something about the clinical picture of small fiber neuropathy. As I told you, pain is the main feature of small fiber neuropathy, and patients describe it as a burning pain or pain with an electrical feeling or the feeling of pins and needles, and that are positive sensory symptoms. But in addition, there are also negative sensory symptoms, and that's a hypoesthesia for pins and needles, for pinprick, and also for thermal sensations. A few years ago, we did a study on the pain dynamics in peripheral neuropathies, in small fiber neuropathy, and we included 165 patients who completed a pain diary on pain. And they finished the pain diary during 4 weeks and 4 days a week. And here you can see the pain scores during that period. And we asked them to score the pain during night and the pain during day. And we asked them to say at what time they experienced the maximum pain. In this picture, the pain during the day is reflected by a sun, and the pain during night with the moon. And as you can see, during the whole period, patients always experience less pain during the day than at night. But when you look in more detail, the pain scores are scored at a scale from 0 to 10. The difference is only 0.4 points. So that's really small. So the meaning of that, is doubtful. You can always also see that the pain during the weekend days is less than during daytime, and that is quite stable during the 4 weeks. In addition, we asked also at what times they experience the maximum pain. And half of the patients complain of pain at rest or during sleep. And that's compatible with the scores at night that were higher. And as you can see, it's quite striking that during exercise, patients don't complain a lot about pain. And maybe that's because they do not a lot of exercise, because we didn't ask them, do you perform exercise at all? Finally, we also asked the patients to point their pain at a body map. And here you can see most of the time, the maximum pain was in the feet or the lower legs. This is also called a length-dependent pattern. So in the longest nerve fibers, the complaint starts. But we know that there also are different patterns of pain. Well, first, you can see the length-dependent pattern. That's most common. But there's also a non-length-dependent pattern with more proximal pain zones and also more patchy distribution. And you can find that in immunological conditions or paraneoplastic conditions. And at last, you can see a focal small fiber neuropathy, for example, burning mouth syndrome or the vulvodynia. And as I told you, the small nerve fibers are not only responsible for pain, but also for the autonomic nervous system. And that's why patients also complain of those autonomic symptoms like orthostatic dizziness, cardiac palpitations, or bowel disturbances. When you perform neurological examination, a lot of tests will be normal. For example, the muscle strength, the tendon reflexes, and the vibration sense. And that's because that are all modalities of the large nerve fibers. You need to perform a thorough sensory examination because otherwise you will find any abnormalities. And in small fiber neuropathy patients, you can find hyperalgesia. And it means that when you give a pain stimulus, the patient feels an increased pain. And the same is for allodynia. That's when a normal stimulus is given that normally provokes no pain, now gives an increased pain reaction. Besides the positive signs, also in neurological examination, there are negative signs. And that means that you can find a hypoesthesia with pinprick tests or a hypoesthesia for thermal tests. Well, after the clinical picture and the neurological examination, you can perform different diagnostic tools to establish the diagnosis. And the last years, we are searching for better diagnostics tools, and I will show some of them. Well, first, before we start to examine the specific small nerve fibers, it's in general, we always perform the normal nerve conduction studies. And with this study, you will examine the large nerve fibers, and you expect an isolated small fiber neuropathy that is completely normal. After that, you want to perform specific small fiber neuropathy tests, and you can do the quantification of small nerve fibers, but you can also test the function of the small nerve fibers. And one test, and the most reliable and common test, is the skin biopsy. And here you can see that we take a small punch biopsy from 3 millimeters, 10 centimeters above the lateral malleolus of the ankle. And when we take a skin biopsy and we stain it, we can see the small nerve fibers that cross the epidermis through the basal membrane. And the arrows point to the small nerve fibers. Well, to see the difference between patients and healthy controls, here I show you 2 different skin biopsies. And in the first picture, you only see 1 nerve fiber that crosses the basal membrane. And in the healthy control, you can see 6 nerve fibers. And we express the nerve fiber density in fibers per millimeter. And as you can see, it's higher in the healthy control than in the patient. But yeah, when do we know if something is normal and is abnormal? Yeah, we know that because there are normative values. They are collected by skin biopsies from 550 healthy persons. And they are collected in 8 different laboratories in USA, Europe, and Asia. And we have chosen different age groups, and we chose to do it for both gender. And we chose the 5th percentile as cutoff value for what is abnormal. So everything below the 5th percentile is considered to be abnormal. And if you have a patient with a clinical picture of small fiber neuropathy, that confirms the diagnosis of small fiber neuropathy. And in this table, you can see that women have a higher intraepidermal nerve fiber density compared to men, and that during the years, when you get older, the nerve fiber density decreases. Another test also to quantify the small nerve fibers is the corneal confocal microscopy. And an advantage compared to the skin biopsy is that this test is non-invasive. And with this test, you can visualize the small nerve fibers in the cornea. And then you can see these pictures. The first pictures show the cornea of healthy persons, and it's comparable with the skin biopsy that in young persons you see a lot of nerve fibers, and in older persons they become less. And in diabetes mellitus, this test has been shown to be a value. Picture A is a healthy control, picture B is a patient with diabetes mellitus, and you can see the great difference. And they also found in diabetes mellitus that it reacts on treatment. In patients that had a pancreas transplantation, there was a regeneration of the nerve fibers. This is a really nice biomarker to check the efficacy of treatment. However, in small fiber neuropathy, larger series are needed to investigate the value of this test. Well, besides the quantification of small nerve fibers, I told you that you can also test the function of small nerve fibers. And the most commonly test is the quantitative sensory testing. And more specific, we perform the temperature threshold testing. And patients are asked to say when they feel a warmth of cold stimulus at their feet and their hands, and then to push the button. And also for this test, there are normative values for age and gender. And then you can see if it fits with small fiber neuropathy. But this test has some really disadvantages because the patients need to be really concentrated and alert, and they need a cooperation of them. And what's also another disadvantage is that it doesn't or it can't discriminate between lesions in the central nervous system and peripheral nervous system. So in any lesion of the somatosensory system, this test can be abnormal. Well, maybe a more reliable test to test the function of the small nerve fibers are the nociceptive evoked potentials. And also with this test, stimulus is given at the skin, but now it's recorded at the skull. So there's no need for a good cooperation of the patient. And as you can see, you can different stimuli. You can do it with a laser or with contact heat evoked potentials or with pain. And for the contact heat evoked potentials, there are normative values. But we found that also in healthy persons, sometimes there are no contact heat evoked potentials. So that makes it difficult to use it in clinical practice for small fiber neuropathy. And again, also for this test, it doesn't discriminate between the central nervous system and the peripheral nervous system. Well, and then finally, not only the quantification of small nerve fibers and the function of the small nerve fibers for pain and thermal sensation, but also autonomic testing could be a test to investigate if there is a small fiber neuropathy. This is a picture of the QSART. It's quite a complicated test, but maybe in future it will also help us with the diagnosis of small fiber neuropathy. At the moment, it is not used widely for that. Well, when can we say it is small fiber neuropathy? The last years, decades, there was a lot of discussion which tests should be the best and which criteria. But recently, the group of Giuseppe Lauria et al. Published a study about the criteria. And in a paper, they suggest that at least there must be a clinical phenotype with typically clinical signs for the diagnosis of small fiber neuropathy. And then the skin biopsy can confirm the diagnosis, and the thermal threshold testing can be also supportive. So this combination is to date the best criteria for the diagnosis. And for pure small fiber neuropathy, it is not allowed to have large nerve fiber involvement. So the muscle strength must be normal, and also the nerve conduction studies. When you look at the epidemiology, small fiber neuropathy is not a rare condition. We did a study 7 years ago here in the south of the Netherlands, and there is a prevalence of 53 persons per 100 inhabitants. And probably the numbers are even higher because there's still a growing awareness for it. And small fiber neuropathy has a great negative impact on quality of life. We performed, the patients completed the questionnaire SF36, and that's a questionnaire for quality of life with 2 domains, physical domain and a mental domain. And in this picture, the blue bars are healthy controls, and the orange bar are small fiber neuropathy patients. And as you can see, for both physical and mental domains, the small fiber neuropathy patients score significantly lower. And when you compare it to other chronic conditions like cardiac conditions or hypertension, the small fiber neuropathy patients also score lower. And if you look more in detail, they score low at the role functioning and at the body pain. Well, when you establish the diagnosis of small fiber neuropathy, it's important to search for associated conditions. And that's because some of them are probably treatable. And as also in other peripheral neuropathy, there are a lot of associated conditions in literature that might be a cause, but the exact pathophysiological mechanisms are still unclear. We performed a large cohort study in almost 1,000 small fiber neuropathy patients. And here I will show you some results of the acquired associated conditions. In almost 20%, an immunological underlying condition was found. In 7.7%, diabetes mellitus or glucose intolerance. And in almost 5%, a vitamin B12 deficiency. And as you can see, the percentage of diabetes is quite low, but that's because in the Netherlands, most of the time they are not referred to the neurologist. So that's why we didn't see them. And in almost 50% of patients, no associated condition was found. And in 25% of patients who had already an associated condition, an extra associated condition was found. So it's always important to do some extra tests when you see a patient with small fiber neuropathy. Well, when a diagnosis is made and you have found an underlying condition, the first step is to treat that underlying condition. But that is not always successful, and then the treatment is insufficient. And that's why there are different algorithms to treat the neuropathic pain. Well, in this algorithm, you can see some pharmacological options. First-line treatment consists of SNRIs and anticonvulsants. If that is insufficient, you can combine the drugs or add weak opioids, or even when that doesn't work, a strong opioid. But those have really strong side effects, and there's the risk for addiction. So be careful with that. And there are also options for focal topical therapy, but you can only use that when you have focal pain. So when there is only pain in the feet, you can do a lidocaine or capsaicin patch. And it's also always important also to have attention for the psychological factors. So to seek help by a psychologist or a psychiatrist, or at a rehabilitation clinic. And when you look at neuropathic pain drugs, the pain relief is quite disappointing. In these patients, only in 50% of patients, a pain relief of 15% will be achieved, so that's quite low. And there are also a lot of side effects, and especially side effects concerning the central nervous system or cardiac side effects. And that's why patients sometimes quit the medication before they could even experience a positive effect of it. And yeah, how could we improve the treatment options? Maybe when we unravel the pathophysiological mechanisms, because when we know where the problem is, we can use that as a target for therapy. And yeah, that was something we were thinking about. And about a decade ago, we did this clinical observation. We had all our patients with painful small fiber neuropathy. And yeah, they had different underlying associated conditions. But yeah, why is it possible that they all have the same clinical phenotype? And we were thinking, might there be a common pathophysiological pathway? And then we were searching for some key players, and then the sodium channels drew our attention. And I'm going to explain why we thought about sodium channels. Here you can see a schematic picture of a voltage-gated sodium channel. And it's a transmembrane polypeptide with 4 domains. And when you fold the domains together, it forms a pore through which the sodium can go into the cell. And there's also an axillary beta subunit, and that is necessary for the anchoring and the kinetics. And in the small nerve fibers, they're preferentially NaV1.7, 1.8, and 1.9 are expressed. And they are encoded respectively by the genes SCN9A, 10A, and 11A. And before thinking of that, there were already some human pain conditions with an SCN9A mutation. First, there is the primary erythromelalgia or erythromalgia. And these patients complain from red, swelling, burning hands and feet, and that aggravates with warmth and exercise. And there's also another condition, paroxysmal extreme pain disorder, also PEPD. And these patients have attacks of pain in the eyes, the jaws, and the buttocks. And these two conditions have in common that there is a gain of function mutation of the SCN9A gene. On the other hand, there are also diseases with loss of function of the SCN9A gene. And for example, this is in the congenital insensitivity of pain. The voltage-gated sodium channels are responsible for the signaling in the nerve fibers, for generation of the action potential. And here you can see in the nociception, when there is a pain stimulus, channel will open, the sodium will go into the cell. There is a depolarization of the cell, and then you will see the action potential. And when the channel is dysfunctional, it can be a spontaneous firing. And yeah, the stimuli will also go to the brain. Yeah, well, how can you study the mutations if they are really gain of function mutations or loss of function mutations? Therefore, you can use the patch clamp analysis, and then you compare a wild type channel with a mutated channel. And then you have 2 different types of patch clamp analysis. First, you have the voltage clamp. And they are using hex cells for that, and that says something about the channel function, so about the different states of the channel. And on the other hand, you have also the current clamp, and then you get information about the channel excitability. You get information about the resting membrane potential, the current threshold, spontaneous firing, and the firing frequency. And for this test, dorsal root ganglion neurons are used from rats. Yeah, and then we were thinking, we had the patients with the SCN9A genes, the erythromelalgia, the PEPD, and they showed some similarities with our small fiber neuropathy patients. So we thought, well, if we do a DNA analysis in these patients, maybe we can find mutations in the SCN9A gene. And for this study, we used patients with an abnormal skin biopsy and abnormal QST, so that were really strict criteria. And in that study, we had 44 patients, and in 8, a mutation was found. So there was a quite high percentage of 28%. And here you can see the different locations of the mutations in the alpha subunit of the NaV1.7 channel. And here is an example of the patch clamp analysis of one of the mutations of these patients. And in this figure, the red lines and red bars reflect the mutation, and the white and the black lines and bars are the wild type channels. And then in C, that reflects the slow inactivation, you can see that the mutated channel has an impaired slow inactivation. In D, you can see that the resting membrane potential is depolarized. In E, that the current threshold is lower, and that results in a higher firing frequency in F and more spontaneous firing in G. And in conclusion, you can say that there is a hyperexcitability of the dorsal root ganglion neurons. Then when we looked at our patients, first I said, well, there's a similar clinical phenotype, but there were some differences. In one particular mutation, the patients had pain, but they also had a lot of autonomic complaints. And in another mutation, the patients only experienced pain without autonomic complaints. And we looked at the different cell backgrounds to find an explanation for that. When we look at the dorsal root ganglion neurons, both mutations had more spontaneous firing. And the firing frequency was also higher for both mutations compared with wild type channels. And the resting membrane potential was lower, and the current threshold was lower. And we concluded that there was hyperexcitability of both mutations in the dorsal root ganglion neurons. And it was, according to the clinical picture with a lot of pain. But when we looked at the sympathetic ganglion neurons, then we saw a difference. The mutation of the patients with a lot of autonomic complaints showed less spontaneous firing. And also the firing frequency was lower. The resting membrane potential was also lower, but the current threshold was higher. So in conclusion, in this ganglion neurons, there was no effect for the mutation with the patients that had only pain, but was hyperexcitable for the patients with a lot of autonomic symptoms. So that's quite interesting that you always have to look at the cell background. Another example for differences in clinical phenotype is that you can have a length dependence pattern, but also a pattern with a lot of facial pain. And to study that, we performed again the patch clamp analysis in dorsal root ganglion neurons, and we saw a hyperexcitability, but we also performed it in trigeminal neurons, and also in these cells there was a hyperexcitability of the neurons. So that's an explanation why these patients had both pain in their face and in their extremities. We also found one family with a striking phenotype. This man has the clinical picture of erythromelalgia, so with the red hand and feet, that's aggravated by warmth and exercise. But this patient had also the clinical symptoms of small fiber neuropathy, and he had really short hand and feet. His father and his brother had the same complaints, but to a lesser extent. And all these persons in his family with this clinical phenotype had a gain of function mutation in the SCN9A gene. And it's interesting that in this patient, both small fiber neuropathy and erythromelalgia was present. So we thought after the finding of the voltage-gated sodium channel mutations in our patients, that it's maybe a spectrum. You have the small fiber neuropathy, erythromelalgia, but also the PEPD. And yeah, they can also share some symptoms of that. Yeah, as I already told you, besides the NaV1.7, also NaV1.8 and NaV1.9 are expressed in the small nerve fibers. And we also studied that in our patients and found mutations. Yeah, the last years we collected about 1,000 patients. And for this study, we had less stringent criteria. because now, we still wanted the typical clinical picture of small fiber neuropathy, but now it was okay if only one of the two examinations, so the skin biopsy or the QST, was abnormal, and some both were abnormal. We did DNA analysis for the SCN9A, 10A, and 11A gene. But when you find a variant, it's important to predict the pathogenicity. And I showed you the patch clamp analysis, but they are quite complicated and time-consuming and really expensive. So it's better to also look at the medical history, the co-segregation in a family, and to use prediction models. And based on that, you can say something about the probability if the mutation or the variant is pathogenic. And here is a flow chart with all the patients that were studied. And in total, we studied 1,100 small fiber neuropathy patients, and in 132, a potentially pathogenic variant in the SCN9, 10, or 11 gene was found. So that's around 12%. And more in detail, we found the most mutations in the SCN9A gene, and 5%. And here you can see in which domain they were found. This is for the SCN10A gene. It's in about 4%. And in the SCN11A gene, it was in 3%. And well, it would be nice if you could predict in a patient if he or she harbors a voltage-gated sodium channel variant or not. So that's why we also look at the clinical characteristics, at the diagnostic tools, but also at the complaints like erythromelalgia, itch, cramps, family history, and in which circumstances the pain increased, like warmth, cold, exercise, or at rest. And here the black bars are the patients without a variant, and the white bars with a variant. And only for the family history and for increase of pain by warmth, there is a difference between patients with a variant and without a variant. And when we subdivide it in the specific variants, there's only a difference for patients with erythromelalgia, and patients with an SCN9A variant more frequently reported erythromelalgia complaints. So overall, there are no great differences in clinical characteristics between patients with or without a voltage-gated sodium channel mutation. So we always advise to perform the DNA analysis in all of those patients. I have showed that with the voltage-gated sodium channel mutations, you can explain the clinical picture of the small fiber neuropathy patients. And it depends on the cell backgrounds in which they are expressed. But we were wondering, can we also explain the axonal degeneration in the skin biopsy? Because when we perform a skin biopsy, we see less neurofibers. And can we explain that by the mutations? And normally, sodium goes into the cell, and then a sodium-calcium exchanger pumps calcium outside the cell. And you can imagine that if there is a lot of sodium into the cell, it will work the other way around, and then calcium will go into the cell, and maybe that can lead to axonal degeneration. Well, the group of Yale studied that in vitro, and the left picture is a wild-type neuron, or a neuron with a wild-type voltage-gated sodium channel, and the three other pictures are of a neuron with a voltage-gated sodium channel mutation that we have found in one of our patients. And as you can see in the bars in the table below, in all mutations, the neurite outgrowth was lower compared to the wild type. And only for one mutation, it was significantly lower. And we were thinking, well, if we then block that channel, does it cause regeneration? Well, it did. Here you can see what happens when you add carbamazepine. You can see you get a regeneration, and the nerves are even more than in the wild type channel. Another probably treatment could be to inhibit the sodium-calcium exchanger. We did that also. And then you can see the same effect as with the sodium channel blocker. So yeah, this proves that the voltage-gated sodium channel gene mutations can cause also the axonal degeneration. And it gives an explanation for the diminished intraepidermal neurofiber density. Yeah, I thought already that the patch clamp analysis are really time consuming and really expensive. And that's why we're searching for a more high throughput model that's easier to test if variants are pathogenic or not. And we developed a zebrafish model, and zebrafish show a lot of similarities with mammals. So that's quite interesting. And we made a model with 2 readouts for small fiber neuropathy. First, we looked at the nerve fiber density in the caudal fin of the fish. And second, more functionally, we tested the reaction of on thermal stimuli. So the zebrafish are swimming in a kind of pool in a zebra box. And when you elevate the temperature, you can see their behavior. Here you can see an example of the pictures of the caudal fin of a zebrafish embryo. And for the studies for small fiber neuropathy, we use the caudal fin of a zebrafish embryo 48 hours post-fertilization. And when you have a healthy zebrafish embryo with a SCN9A wild type channel, this is the density. And then when you have a fish with a mutated SCN9A gene, then you can see the density is decreased. So that's really nice that you have a good readout for that. Then when you look at the swim activity, here the gray line is the fish, the healthy fish with the wild type channel, and the black line is the fish with the mutated channel. And as you can see, when the temperature is rising from the water of the fish with the mutated channel is swimming more actively. And we think that it's a kind of allodynia because it's unpleasant that they feel the warm water. And at the right picture, you can also see that the maximum activity is higher for the mutated fish. So yeah, the zebrafish model is a nice model to study the pathogenicity of the voltage-gated sodium channel variants. Well, yeah, why is it necessary that we found the voltage-gated sodium channels mutations? We can use it for targeted treatment, as I told before. Lacosamide is a sodium channel blocker that was already used in the treatment of epilepsy. And this sodium channel blocker selectively blocks NaV1.3, 1.7, and 1.8. And it enhances the slow inactivation state. And the target is especially the hyperexcitable neurons. And we performed a randomized placebo-controlled double-blind crossover design study in 25 patients with an SCN9A gene mutation. And all patients were treated with lacosamide and with a placebo, but they didn't know in which order. So they were randomized, and then they received or first the lacosamide or first the placebo. And after a tapering down period and a washout period, they get it the other way around. And here you can see some of the results. In this picture, the mean of weekly average pain scores are shown. And this is, again, the pain score on a scale from 0 to 10. And the patients with the right line first received lacosamide, and in the second period, the placebo. And the patients with the blue line first received placebo, and in the second part, the lacosamide. And as you can see, during the lacosamide periods, patients experience less pain compared to placebo. And here you can see it in another way. when you compare treatment with lacosamide versus placebo, a 1-point decrease in mean average pain was received in 60% of patients with lacosamide versus 21 treated with placebo. And when you look at even a greater decrease from 2 points, it's 33% versus 8.7%. And we also asked the patients how they felt generally with the PAGIC, and 40% of patients during the lacosamide period felt that they were very much improved compared to 12% in the placebo group. So that were really nice results, and yeah, it confirms that more selectively sodium channel blockers can be used in these patients. Well, I told that we have found in 12% of patients voltage-gated sodium channel genes mutations. So in more than 80% of patients, we didn't find any mutations. So we think there are other genetic factors, and we are searching for other genes. We are involved in 2 European Union funded projects, for pain study and a PayNet project. And yeah, the upcoming years, we will show the results of that. But besides genes for channels, the sodium channels or calcium channels or other channels, there might also be a role for the mitochondria. And normally the mitochondria, they travel from the cell body through the axon to distally. And during that transport, they can get damaged. And especially with age, it can become worse. And yeah, as you can see, the most distally parts of the nerves are most vulnerable. And that's why yeah, you can imagine that in peripheral neuropathy, mitochondria may play a role. And we know that in the small nerve fibers, that the density of mitochondria is quite high, and that dysfunctional mitochondria have been found in painful neuropathies, and especially in chemotherapy-induced painful neuropathy, diabetes neuropathy, and HIV neuropathy. Yeah, studies show these findings. And yeah, the mitochondria can be dysfunctional in different ways. The fusion and fission are processes that are really important for the function of the neurons. And we have looked if a problem in the fission maybe could lead to small fiber neuropathy in our zebrafish model of small fiber neuropathy. So we had the zebrafish, and we knocked down a fission gene, and we expected that it would lead to a diminished nerve fiber density. And here you can see the results. Completely to the right is the normal zebrafish, and to the left is the fish with the knockout of that fission gene. And as you can see, indeed, there is a reduced nerve fiber density. And also for the swimming activity, yeah, we found similar results as I showed earlier for the voltage-gated sodium channel genes. There is a abnormal swimming activity in the fishes with a disturbed fission of the mitochondria. So that's a nice proof of concept. And it was also really nice for the zebrafish models that it not only can be used to test if some genes or gene mutations are pathogenic, but you can also add a compound for treatment and to check if that will diminish the complaints of the fish with the small fiber neuropathy. Okay, in conclusion, small fiber neuropathy is a painful neuropathy involving selectively the A delta and C fibers. And typical clinical signs are required to establish the diagnosis. The skin biopsy and quantitative sensory testing are confirmatory diagnostic tests, and current treatment options are disappointing. The voltage-gated sodium channel mutations play an important role in the pathophysiology of small fiber neuropathy, but there is a possible role for other genes. And these gene mutations are important because they are the key to targeted treatment. And the zebrafish model is promising to study new mutations and for testing new treatment options. Well, thank you for your attention. And I also want to thank my colleagues from the Netherlands, but also from Yale University and Milano, because they were also involved in all of these projects and and in all the studies.
Thank you, Janneke. That was a brilliant talk, and I think that it had the right amount of combination between things that are clinical, and many of us are keen to learn about the clinical side of it, because it helps us deal with our patients. But you provided also a lot of mechanism and substrate information that is helpful. Mm-hmm. So if you're happy, we have now one question from Alejandra Perez del Real. She can unmute yourself. You can answer live, please. You can put your question live if you want. Otherwise, I can read it. You can unmute yourself, Alejandra.
Okay. Hello. Thank you very much for such a fantastic and attractive chat. I was very surprised by the idea of this sodium channel blockers, and I would like to know whether you find they might be applicable to peripheral autoimmune conditions such as GBS and CIDP.
And thank you for your question. And the question if they also could work in that conditions or not.
Yeah.
Yes. Well, we know that also in large neurofibril conditions like GBS, also sodium channels are involved, but that are different sodium channels. And in the pain in GBS, also the sodium channels are involved. So it might diminish the pain. But if it also will work to the complete illness, that's questionable, because it will not help for the complete pathophysiology of the disease. But now we tested it only in patients with a sodium channel mutation, but we think it will also help in patients without a mutation, because the sodium channels are involved in the pain signaling. So when there is a problem and you block the channel, you expect that it also will work for patients without a mutation.
Thank you very much.
Okay, so at the moment, I cannot see other questions, so I'm going to step in while they think what to think about or to ask about. So, Janneke, would you mind stop sharing your screen?
Yes.
And I will show something on my side. So, yes, here it is. Right. It's taking a bit too long.
Yeah, it's a bit slow.
Okay, so I think now you're looking at the slide from this systematic review and meta-analysis. I'm sure you're acquainted with it. Mm-hmm. And of course, my question, of course, you've showed very elegant study about glucosamide, a sodium channel blocker, which in concept would be a very good therapy for the channel sodium channel related forms of these neuropathies. But if you look at my slide on the division A, for instance, about the pain reduction, and then you look to the right and see the medication stride, it's true that the numbers in between brackets mean the number of time points for collection of data. You will see that probably it seems like that it's not necessarily the medications that are sodium channel blockers that work the best. So you'll find, for instance, the GABAergic medications on top of the sodium channel blockers.
Yes.
And of course, this is a bit debatable, and this meta-analysis, for instance, is not exactly fantastic in terms of effectiveness of treatments, as you've said in your talk. And the only one that looks better, it's the visual analog scale on the division B. I wonder if that's there is any bias in the visual analog scale that makes patients feel better about the medication. I don't know. So how do you explain, or what's your comments about these lists of medications and the relative efficiency of them, namely in terms of the sodium channel blockers?
Yeah, well, the sodium channel blockers that are commercially available, like carbamazepine, that's the most common sodium channel blocker, they are not selective. So they always also block the sodium channels in the brain, and it causes a lot of side effects. So before you reach an adequate dosage for diminishing the pain, yeah, they have so many side effects that they need to stop with a sodium channel blocker. So that might be a reason, why there is less pain reduction, because they don't use the right dosage for also blocking the sodium channels in the peripheral nerves. And yeah, there will be also other mechanisms in the other patients without sodium channel mutations that cause the pain, and maybe for that patients the other drugs are better. But yeah, in most of the drugs give some pain relief, but yeah, it's not that sufficient in most of the patients.
So that's not the case for lacosamide, which is specific.
Quite specific.
Yes.
Not completely, because it's an anti-epileptic drug, but more than the carbamazepine.
In terms of the lacosamide, sorry, this paused the sharing. In terms of the lacosamide, did you have side effects because of it or not?
Yeah, there were some side effects, but they were not that bad. So some had a bit of dizziness or headache, but they were not substantial.
Not vomits, because in epilepsy, vomits are one of the side effects, or nausea, it's one of the side effects.
Yeah, I'm not sure, but not in a lot of patients.
Okay, good, excellent. So I'm going to stop my sharing. This is not useful anymore. Let's see, we have here someone on the chat.
Yep.
So it's Terezinha. Welcome, Terezinha. So please unmute yourself and voice your question.
Hi, Yannick. Thank you for this great talk. I'd like to know, because, well, it's been a long time since I've dealt with small fiber neuropathies, but small fiber neuropathy symptoms are considered one of the first symptoms, for instance, in familial amyloidotic polyneuropathy, namely in TTR, associated with TTR mutations. I was wondering if in such a huge cohort as the one that you have collected, if you have patients with mutations, especially in TTR.
Yes, thank you. That's a really good question. We are in the Netherlands. We are the only center of expertise for small fiber neuropathy. So we see a lot of small fiber neuropathy patients from all over the Netherlands that have the first complaints is small fiber neuropathy. So it's an interesting group to look if they have FOP. And the last years, we have the TTR gene in our gene panel. But we never found a mutation in that gene, and I think that we already have tested about 500 patients. So yeah, until now we didn't find it. I can imagine that someday we will find a mutation. Yeah.
You should have a collaboration with our Portuguese colleagues, because they have a lot of small fiber neuropathies and FAP.
Yes, I know. Yes.
FAP.
Yeah. I saw some really interesting talks from them. Yes.
Do I have the right to ask another question?
Of course.
It was. I thought it was really, really interesting when you were talking about the corneal confocal microscopy.
Mm-hmm.
Is something that you are already. I understood that there's still a need for normative values and better, but it's something that you are already studying.
Yes, we are studying that. Yeah, the normative values are collected. So there's a really nice article about that. And now we did the examination in 200 small fiber neuropathy patients, but we are still analyzing it. And yeah, it's questionable if it will be a good study in all patients with small fiber neuropathy, or maybe only the patients with a non-lang dependent pattern, because yeah, the eye maybe it reflects the non-lang dependent patients. But until now, yeah, we are still analyzing and waiting for the results.
Thank you. I'm going to mute myself now.
Okay, just the last one. So you have sometimes patients that have very similar involvement in terms of small fiber neuropathy with very different intensities of pain, don't you?
Mm-hmm.
And so where does the brain come into it? Because there are some biomarkers in the brain saying that those patients with pain may be different from the others. So
yes.
What's your take on that?
Well, at the moment, we are performing an fMRI study yeah, to compare patients with small fiber neuropathy to healthy controls. And in that study, they get a warmth stimulus. And then we can also see the reaction on that. So if there is a different pain signaling in the patients and in the healthy controls. And we have a group of idiopathic small fiber neuropathy patients and a group of patients with a sodium channel gene mutation. So yeah, it's really interesting what the results will be. Yeah.
Okay. When are you published? You don't know.
Well, we finish it, I think, at the end of the year. So next summer or something like that.
Okay, good.
Yeah.
So I don't see any more questions. And so I'm going to thank you very much for this marvelous presentation and this very good discussion. And we'll keep in touch, hopefully. And thank you very much. And thank you to everybody who's been present. As you know, there will be a small survey at the end of this session for the people attending through Zoom. And by filling the survey, you may opt to fill it anonymously or to fill it with your email, because if you put your email, you will receive a certificate of attendance. So until the next webinar, bye now. Thank you.
Thank you.